Sure, sure, sure.
Yes.
Great, great, great.
Okay.
Yeah, I think some people are responding on the chat. Yes, everybody said good morning, and as we can see, yeah. So Victor, Abdul Latif, and JNU.
JNU is Dr. Newsom, I'm pretty sure.
Newsom here. I can hear you. Good morning, everyone.
Morning.
Okay, so I'm gonna make you the host.
Okay.
Make you the co-host. 1, 2. Okay, I think if you want to go ahead, that's good. Most people will trickle in by around the 10th minute. That's what I've realized.
Yeah, but we got enough people already, like nearly 15 students there. So you want me to go ahead and start the presentation, or wait for another 5 minutes?
I think we can start. And thanks again for volunteering to teach us.
Oh, no problem. Thanks at all. Thank you for the opportunity, I would always say. So good morning, everyone. Today I'm talking on portable chest radiographs and in the blunt trauma. And most of the cases, I'll try to show you the CT correlation so that you will understand how exactly we will be managing the patients. So the reason why I call the portable chest radiographs is most of the radiographs which are taken in trauma where the patient is not in a position to stand or cooperate with our guidelines of the ideal way of chest X-ray, which is PA view of chest X-ray, which we call, and they'll be these trauma radiographs are taken on the bedside mostly. That's the reason why we use the word portable. It has its own limitations. So making yourself comfortable and confident about the reading of a chest X-ray, especially the portable chest X-ray, is not that easy. It takes some time and also some skill. So, but I'll try to do my best. You can see some of the radiographs which I show you may have this word portable, supine. So that's what I want the medical students to understand when they're looking at a chest radiograph. Don't jump into diagnoses or, hey, this may be a case of pneumothorax, pleural effusion. So instead of that, pay attention, like what exactly the radiograph reads like. For example, a portable is taken on the bedside when the patient is still on the bed. The radiographer or the technician takes his X-ray machine there and then shoots a film there. That's how it works. This is case 1 for you. And case 2, what could be the diagnosis in this patient? A little bit tricky one. Unless you have seen so many radiographs, it is difficult to pick up. This is an obvious one, but here I want you to make a list of the differential diagnosis. Like when you see a patient with entire opacification of entire left hemithorax, what comes to your mind? What is going on? So for today's lecture, the learning objectives, the chest radiograph appearance of trauma patient. I'll go through the checklist in a couple of minutes, but that's what I'm going to tell you today, like how exactly you have to look at chest radiographs in case of trauma and identify the chest radiograph findings that can suggest some diagnosis, or most importantly and most commonly, they narrow the differential for traumatic injuries to thorax. And then for some of the cases, or maybe most of the cases, I added a cross-sectional correlation to chest radiograph. Cross-sectional here means you are going through the body, like for example, ultrasound, CT, MR, they are the cross-sectional imaging. So they have enormous advantage compared to the two-dimensional images. So I'll show you some examples there. So introduction to the blunt trauma thorax. Today, I'm confining my lecture to blunt traumas. The trauma is like blunt and penetrating. If in the future lectures, if time permits, I may do one on penetrating trauma to both chest and abdomen too. But for now, this typically make your ideas confined to the blunt trauma of the thorax. It is the third most common injuries. Injuries to the chest are the third most common, next to the injuries to head and extremities, which are first and two. And then overall fatality of a blunt trauma chest is up to 10%, which is significant. Positive findings can complicate overall case management. Like for example, if you have a positive chest X-ray or a positive CT finding for in a CT chest, you may have a long course for the patient. Maybe it may be the hospital stay, it may be the complexity of the other associated injuries. More than 2/3 are from motor vehicle collision, especially in our setting, in our Western community and developing nations, it is the motor vehicle collisions. And then others are due to falls and blows or assaults. And the CT is far superior. We have enough data, but today I'll try to make sure you understand what exactly you have to do with when you look at a chest X-ray, or what we are doing when we look at a chest X-ray. So chest X-ray is still the initial imaging investigation in most level 1 traumas, and can even decide the management sometimes. For instance, imagine you see a huge tension pneumothorax. You can immediately call, even before the patient moves to CT scanner, we can say why the patient is in shortness of breath. The radiograph triage, which we call it as the primary evaluation in level 1 traumas. Level 1 trauma is, we work in a level 1 trauma, which is our Grady hospital. And the way we do chest radiographs, it helps to stage the imaging studies and identify life-saving interventions. For example, as I said, the pneumothorax, especially the tension pneumothorax. And it helps to ensure the patient is hemodynamically stable or not. So the conflict here is some authors have a contradictory opinion, and there is enough literature search now from 2006 to 2018. There are many reports. Some authors believe that if the patient is hemodynamically stable, they may not need a chest X-ray. But right now, we are not strictly following this protocol because most of the times the patients may be unconscious. You don't know what exactly is the history. So we are on the go ahead and make a chest radiograph. And this is our basic primary evaluation in the radiology. The patient will get a chest radiograph. And you can see here, again, instead of jumping onto looking at the images, see what is written there. It's written as trauma, supine. So this is a supine radiograph, trauma. For a trauma case, the moment this comes, my checklist pattern is different, and the way I look at it becomes different. And they also provide a pelvic radiograph to make sure that how exactly this case is going to. The examples which I showed there are absolutely unremarkable, but at the same time, there is a positive case here, which is a case example for you. And I think one of the cases also, I have included this as one of the case presentations here. So again, come back to here. This is the medical students should be very careful why this case says portable, why this case says trauma, because it comes with some limitations. So this is a chest radiograph in a motor vehicle collision. I'll come back to the findings when I start describing each case and my checklist. So what exactly is a checklist we try to advocate or we try to follow in a case of a blunt trauma chest? So this is how I look at them. Any chest radiograph, the tubes and lines become very important to observe and notify the ordering physician what exactly is going on with the patient. And next comes the mediastinal widening and gas, finding a gas in any abnormal areas like the soft tissues, mediastinum, pleura. Everything makes a clinical implication. And pulmonary and pleural injuries and diaphragmatic injuries, which are sometimes maybe very tricky, but they can be catastrophic. Musculoskeletal injuries, unless you pay a dedicated attention, it's difficult to pick up all the musculoskeletal injuries in a chest radiograph. So to begin with the tubes and lines, so this is my case one here. So anybody wants to talk about the findings in the image on your left? The chat box is empty. So you don't have any clue? So here, patient is intubated. You can see the ET tube in the trachea. This is the bifurcation of the trachea, which is called carina. We usually we see that the ET tube tip is like a 3 centimeter away from the carina. It should not, the most important is it should not enter into any of the bronchi here. So if you see, the patient also has another tube. Usually it is the NG tube. I cannot comment because I'm not seeing the tip there. But if you see, it coils back in the proximal esophagus, and it is going back. So this is a coiling back NG tube within the proximal esophagus. Probably the clinician might know, but still you have to give them a call and let them know. And the next case here is the NG tube here entering into the right main bronchus. You see the tiny radiolucency here. That is an identification mark for an NG tube. And this patient was intubated, and then patient also put a NG tube and which went into the right main bronchus. These are the ones which need immediate call. And this is a regular tubes and lines of chest radiograph class, but do not forget that you have to talk about this even in your cases of trauma. So these are a little bit more complex cases where I'm trying to show you a empty trachea here, but the patient is intubated. You can see the endotracheal tube next to the trachea. Sorry about that. So next to the trachea, but the trachea is empty, and this was placed in the esophagus. This is a ET tube going into the esophagus, which we had to call immediately, and they had to take it back. And then the second case on your right, the patient is intubated. The NG tube is also almost going into the stomach. So both tubes and lines are all right, but what exactly is wrong with this image? If you look carefully, during the intubation, there's always a chance that we may injure the patient's teeth. And if the tooth comes out, they may aspirate the tooth. So this is a tooth within the right lower bronchus. This can, if this is missed in the initial evaluation, the patient, you may treat the patient for trauma and its complications, but he will end up in obstructive pneumonia, fever, and septicemia. So these are some of the classical examples which I always show to my residents to understand the ramifications of if anything is missed during the assessment of the tubes and the lines. Moving on, this is a chest radiograph. Anybody wants to see anybody wants to talk about this? Anything wrong? It is not about tubes. We are moving to the next topic here. So don't worry about the coiling of the NG tube in the proximal stomach. And this is a comparison, how exactly a normal mediastinum looks. This is an abnormal mediastinum. So what do you think? Anybody is willing to volunteer for this case? Okay, I see some images there. Yeah, there's some chart box that helps me a lot. Oh, very good. So Victor, good job there. It's a mediastinal widening. So rest of the people think what can cause mediastinal widening and how significant is this in a trauma? So yes, he is right. It is mediastinal widening. So one is mediastinal is widened, but if you look at the aorta in this, look on the images on the right. So somebody is chatting aortic. No, we are looking Abdul Latif. Yeah, good answer. But mediastinal widening is different. Aortic aneurysm is different. Aneurysm has a contour. It will not cause a bilateral mediastinal widening. That too in a trauma. Aneurysm is less common, maybe a pseudoaneurysm you're talking about. So compare with the normal aortic contour here. This has a very indistinct, you have to search for the contour of the aorta in this image, which is seen through a soft tissue window. And the mediastinum widening is called when it is more than 8 centimeter, but I don't go with the measurement at all. I go more with the way how the superior mediastinum looks. Tracheal deviation, very minimal in this patient, not that much. Loss of aortopulmonary window. This is called your aortopulmonary window here. And you do not see, instead you see a bulging of the aortopulmonary window. That is another sign of mediastinal widening. And you may have associated hemothorax and pneumothorax, which are not there in this patient. Okay, so again, another case of mediastinal widening. Anybody wants to talk about any other findings in this patient? Doreen says hemorrhage. Yes, dissection is one thing, but I'll come to that immediately, Irene. And Doreen, good answer, hemorrhage in the mediastinum. That's called mediastinal hemorrhage. Okay, so anybody wants to share their ideas on this image?
And it's okay to describe the findings, even if you don't know the diagnosis or what.
Yeah, you don't talk about the diagnosis. I just want you to see what you're seeing, because I said so far I talked about tubes, so far I talked about trachea, so far I talked about mediastinum. So I want you to think in those lines. I will be narrowing it down to you. I don't want to give all diagnosis. Hazy lung, don't talk about lungs for now. We will go there eventually. I'm talking about the mediastinum. I want you to think about what is your clinical examination. Again, notice the trauma, notice the portable supine. What do you do to a patient when somebody comes with a breathlessness or some stridor or difficulty in swallowing? How do you examine the patient on your palpation? When you palpate the neck, what are the important things you do? Okay, I think I can reveal the answer for you here. Where is the trachea? You see, is it in the midline? Trachea, I gave a clue there because, yeah, very good. The trachea is deviated to the right. It could be due to patient orientation, but definitely this is a significant deviation there. That's one sign you have to see. And this is a case of mediastinal widening. And now coming to the CT image, this is where I will say the comparison. So how exactly this works is when you see such a patient And when you know that this is from a trauma, especially from a motor vehicle collision, the patient having chest pain or not chest pain, you have to alert the clinician that he needs, say, CT immediately. So this is a CT of a patient. Look at the normal aortic lumen here, the normal contour, and no intraluminal opacities or no intraluminal densities or hypoattenuation or tiny membranes. That's what I look for when I look at the aortic lumen. Whereas you come to the aortic arch, you see a tiny flap there. We call these any floating membranes within the aortic lumen are called a flap. To be specific, if anybody is reading your physiology and pathophysiologies of aortic injuries or aortic dissections, this is called intimomedial flaps. Earlier, they used to call it as intimal flaps, but now the pathology research says that it has both intima and also media in it. So that they are known as intimomedial flaps. Remember your basic anatomy of the aorta. It has the aortic wall, which is adventitia, and then the media, and then the intima. So this is an intimomedial flap here. And you can see the surrounding fat attenuation. It's supposed to be all fat here, but you can see hyperdense fluid surrounding the superior mediastinum. And same thing here, you can see the intimomedial flaps here, and you can see the mediastinal hematoma. Sagittal and coronal views give a phenomenal advantage of looking at the aorta. You can see the flaps there. It could be there is a partial transection of the aorta here. And for comparison, so that's what I tried to do. This is a comparison of a normal CT at the same level, like at the aortic arch level, where for medical students, it will be a good comparison. You should be able to see the esophagus. You should be able to see the esophagus vein here, and you should be able to see the mediastinal fat, which are not seen in these positive mediastinal hematoma with aortic injury. So the mechanism of aortic injury is very important to understand. This is a slide which I make for my residents, but briefly, I will tell that whenever a patient is driving and sudden deceleration happens, and if he hits the steering or the wheel in the car, that's most common mechanism where the pinching, the osseous pinch from the sternum hits the aorta. That's one kind of mechanism. And then the water hammer effect. Water hammer effect is more hypothetical, where there is a sudden occlusion of the flow to the blood. But most important thing for you to remember is what exactly is the site of injury and why. Wherever in a trauma patient, like for example, an aortic injury, the areas which get more affected are where they're fixed. Where they're fixed, the injury is more common. Like for example, aortic root. For example, the ligamentum arteriosum, which is after the distal to the subclavian artery. This is where a tiny tethering ligament exists. That's a fixed point for the aorta, and that's where the most common site of injury. So what are all the teaching points which you need to know is I already showed you one nice radiograph. Be aware of what exactly is a mediastinal widening. Even if you may be going into radiology or you may be going into a clinical team, if the radiologist is still working on his images, and if you suddenly notice a radiograph where there is mediastinal widening, hey, can you look at this radiograph? I'm having my own questions. The patient's mechanism is in favor of aortic injury. So we don't mind getting those calls. It is all, we all work for the interest of the patients. So make that habit, make yourself confident about findings. You can just put like a question. Hey, I'm thinking my patient might be having a mediastinal widening. Is it a fake or real? So it's mostly due to rapid deceleration injuries, intimal tear, which is also called as intimomedial tear nowadays. And most common sites are at attachments like the aortic root and the ligamentum arteriosum. And most commonly on CT is more useful here because we may have to look into the pseudoaneurysms, intramural hematomas, lacerations, and dissections. Another thing which the medical student should be aware of, the treatment has enormously changed. Open surgical treatment for transections, but you have to understand the conservative management of these patients is on the rise. When they're stable, they can be managed with an endovascular repair. Here is an example where you can see the endovascular stent. This is the same patient after the treatment. And some patients with a minimal aortic injury can also be managed with medical management. These are some case examples. I was talking about ligamentum arteriosum. You can see that the image on your extreme left, you see a tiny sharp membrane here. That is a flap. It's a dissection flap there. And in this patient, you at the next to proximal, the distal to the ligamentum arteriosum, you can see an outpouching, and next to the dissection flap there, this is a pseudoaneurysm. This is the axial image of a pseudoaneurysm, but more importantly, you have to look at the mediastinal hematoma. So these are all like, how the patient prognosis will be depending on. So the mediastinal widening, there is one pitfall, because that's why I said, like, whenever you have a supine, this is a mobile radiograph taken, and then the patient appears to have a mediastinal widening, which is because of the patient positioning and the tube positioning. But the same patient, when a radiograph was repeated on standing position in a PA view, you can see everything absolutely unremarkable. This is the area where you and the radiologist both have to work together as a team. What is the clinical symptoms? So always remember that mediastinal widening in a supine view can be very confusing. And this is one of, even I've been an attending for the last 4 years. Whenever I see a mediastinal widening, there at least once in a while, I overcalled and we initiated a CT, which was like a negative. But the thing, if the patient is stable, the best way to do is repeat a chest radiograph at least by a sitting position, where you will see the normal aortic contour. This is the case number 2, a little bit atypical. So I think I cannot expect you guys to answer this. So the patient on day 1 and on day 2, the patient deteriorated a little bit, started having some amount of shortness of breath. So what do you see? So this is a soft tissue emphysema, which was not there in the previous day. Somebody answering, very good. Reduced vascular markings. So always remember, Victor, this is we're dealing with trauma. So I'm trying to show you the obvious findings. I'm not trying to teach you or cheat you. So this is like a real things which make some difference in the management of the patient. So, and also you can see a tiny layer of gas along the mediastinum. This is called the pneumomediastinum. These are the ones which needs to be further evaluated. If somebody can see it, all the superior soft tissues in the neck also have some gas. This is called the soft tissue emphysema with pneumomediastinum, needs a CT, and we did a CT. This is what we saw. This is a lung window of the superior aspect of the chest where you see extensive gas pockets within the soft tissues, and you can see the pneumomediastinum, but no pneumothorax. So this is one of the common presentations of tracheobronchial injury. So it could be spontaneous, it could be due to trauma patients. In trauma, the 2 things which you have to be very sure is, could it be due to a alveolar injury or a bronchial injury? So for that, you may have to do a bronchoscopy confirmation to see the bronchial injury. Not every time you can see the bronchial injury on CTs. It is again due to deceleration injuries. It is the elevated intrathoracic pressure in a closed glottis is the most common mechanism explained. If there may be a concomitant injury, so that's the reason why we usually opt for a CT. Usually goes for a surgical repair, and in the other setting, you have to remember alveolar and interstitial injuries, like in asthma patients, in a chronic obstructive pneumonia patient. So those are all the ones which have. This is somebody has to take a look at this case, and I'll give you a couple of seconds. You find any abnormality. Remember, we are in the domain of air lucencies, abnormal pocket of air in abnormal areas. So that's what I'm giving you the clue there, what exactly I'm looking for. So, and the abnormality is on the left side of the chest. One more clue I'm giving you. And if you're still not getting it, go to the periphery of the lung. Still, I don't see any. So I have to reveal the answer for you. Now, are you able to see it and comment? Very common diagnosis. Finally, I see some answer. Very good, Salim. Good job, Salim. So this is a pneumothorax. You can see the pleura is having a reasonable or a decent pocket of gas here. That's descriptively, I say like a moderate pneumothorax, definitely not a tension pneumothorax. And these are called inverted image of the same patient, where sometimes I find the lucency or the visceral pleura. This is the visceral pleura, the air accumulating between the parietal and the visceral pleura, and the visceral pleura can be better identified in an inverted image. So this is a pneumothorax. Good job. So what are occult pneumothoraces? This is one important thing. So this is a patient which came with a shortness of breath, not a significant mechanism of trauma. So whenever I talk to clinicians, I'll ask, what is the mechanism? I don't want to know what exactly happened during the accident. When I say what is the mechanism, the two things which the clinician and radiologist share is, what if they know what is the speed of the vehicle, or is it like a mild, moderate, or a severe mechanism of injury? By talking to the paramedics, they give me that information. So they gave me a mild mechanism of injury. Speed was not known in this patient. But for example, imagine a patient driving at a speed of 30 to 40 miles per hour, meeting with an accident, and a patient who is at 70 to 80 miles per hour and 100 miles per hour. Imagine make your story there. So something there, pneumothorax, very good. So this is like a patient which we were not comfortable. Still, I see some apical lucency there, but I'm not sure what it is. So this patient went for a CT scan. And what is the diagnosis? Yeah, I know this isn't obvious, so I should be expecting some more answers here. Very good. Let me see what people are. Yes. So left-sided pneumothorax here, which is not really picked up on radiograph. So these are the ones which we call occult pneumothoraces. So what is the clinical significance of these one is, if you and I don't pick them up on our discussion, what happens is, if the patient is subjected to any positive mechanical ventilation for any reason, or if he has to undergo a general anesthesia with the endotracheal tube placement, that's when the tiny occult pneumothorax becomes big, and it may even cause tension pneumothorax. So that's how knowing all these subtle things on the chest radiographs makes a difference in the management of the patient. So this is a patient with a pitfall in imaging. So this is almost similar to the case. So you see that there's a tiny marking there. But one more thing you have to notice here is, even beyond the marking, you can see some amount of lung parenchyma. This is a classic presentation of a skin fold. Most of the patients in trauma, or most of the patients in the ICUs, they have these, like, they'll be lying down for a long time, and they may be having a lot of lines and tubes over them. So these are the ones which you have to be very careful. So the way the radiologist finds out is, if beyond this line or marking, if I see still the vascular markings of the lung parenchyma, we try not to diagnose it as pneumothorax or talk to you or repeat the radiograph and make sure that we are not dealing with a pneumothorax. The teaching points: 15 to 40% of the blunt chest trauma patients can have pneumothorax, and the ruptured alveoli due to a sudden increase in the intrathoracic pressure or a blunt crushing force, or as usual, most of the thoracic injuries are due to deceleration injuries. Up to 15% are not visualized on chest X-ray. Occult pneumothorax, I have discussed this in detailed way, and the ramifications if you don't diagnose it. And management is mostly relies on the symptoms and physiologic response, but I still say that follow your institute guidelines for pneumothorax. Some people like measuring the pneumothorax, which right now we talk to the clinician, tell them, is it symptomatic or not? Because most of them resolve spontaneously. Some may look big, but don't need any tube. So that's still, the debate is going on. There is no proper research for that. But beware of skin folds. Being young residents, you may have to look at the skin folds topic a little bit more carefully, and not to overcall or not to alert any of the team saying that, hey, I diagnosed a pneumothorax because I listened to a lecture. So now I'm able to, sorry about that. So this is moving on. This is a chest radiograph in a blunt trauma patient. The initial chest radiograph, my reading was negative, normal chest radiograph, no trauma-related findings. I would have been more careful, but that's what I could do in a busy setting. Retrospectively, I see something there, but after 6 hours, patient was not doing comfortable. After 6 hours, the patient, they had repeated a chest radiograph. So what do you think the diagnosis is? This is about the parenchymal opacities. So to narrow down, so anybody wants to throw some diagnosis there? What this could be? You can give, even if you give a wrong, even if you say pneumothorax, I take it. But say something. I don't see any answers. That's fine. We have to go for a CT here. Any more now? Very good. Consolidation is a right word I expect from the medical students. Yes, this is all consolidation, but it is very randomly distributed, right? It doesn't respect, very good. This is Salim, very good job. So this is a randomly distributed opacities, relative subpleural sparing. It doesn't respect the borders, and it's almost occupying like 2-3 segments here, and some even in the posterior aspect of the lung. So this is a classic case of pulmonary contusion. Yes, I agree. I totally take the consolidation word here, because any opacification of the lung parenchyma can be called as consolidation. It could be opacified with a blood, pus, or fluid. So Apache airspace opacities or consolidation. So I give Salim complete points there, because he used the word consolidation. It is distributed irrespective of the bronchopulmonary segmental anatomy. So the way you differentiate from a pneumonia is, one is pneumonias will have 8 bronchograms, and it has a segmental distribution. Whereas the contusion, which is a trauma and a random injury, they won't respect any of the bronchopulmonary segments. And this is a subpleural sparing. You guys need not understand this part. This is more of a radiological part. The difference between CT and X-ray here is CT recognizes the contusion immediately, whereas radiographs take 6 hours time to identify the consolidation or a contusion. That's the reason why I showed you a radiograph at initial evaluation and then after 6 hours. Everybody now knows what exactly is a consolidation. Look at anybody wants to describe the findings on this radiograph verbally, not typing, because I want you to anybody wants to talk about this chest radiograph, because I discussed the findings one by one. If anybody is interested to volunteer, what are the chest radiograph findings here? Okay, that's fine. Let's in view of the time, we should better move on. So if you compare with the left lung parenchyma and the right lung parenchyma, you see entire opacities, and we know that we are all discussing the cases of the trauma. So when you cases of trauma, lung opacities, the first thing that should come to your mind is pulmonary contusions. That's entire lung is pulmonary contusions there, and you can see multiple opacities there. So this is all the pulmonary contusion, but I'm also trying to show you some amounts of air pockets within the contusion. So what are all these? So whenever you're looking at a pulmonary contusion, look carefully for any areas of elliptical shaped cavities, which are very common in trauma. So these are the pulmonary lacerations. Lacerations in visceral organs are slightly different from lacerations in the lung parenchyma. Lung parenchyma has highest elastic recoil. So whenever there is a cut through the lung parenchyma, it tries to contract in an elliptical way. So that's the reason why you see like a cavity-like lesion instead of opening up of the tissue. So contusions resolve in 24 to 48 hours. And most importantly, if you see an opacity after 24 hours, you have to think other than contusion. It could be aspiration, it could be pneumonia, whereas the laceration is more important to include it in the reports, because for two reasons. One is they take longer time to heal. Sometimes they take even months. And most importantly for me is they can have the tendency to form abscesses and secondary infection. So this is an example of it is a patient with trauma where you see opacities here. Every opacity in a trauma is not a contusion. You can see some dependent debris in the trachea, which can be seen in every case of trauma. So I'm just trying to show you that this is a case of classic case of aspiration in a trauma patient. This is a differentiation between the contusion and an aspiration. Okay, moving on. This is okay. Now you should be able to answer this pretty quickly. What is the diagnosis, one, and what else do you find in this patient? Very good. I got some answers there. Very good. Total opacification, says Salim, and then lung collapse. If the lung collapse, it drags the mediastinum towards it rather than pushing it to the opposite side. Very good. So yeah, thanks for answering. I'm not going to be picky here. I'm going to tell you the findings. The findings are, you see a lung parenchyma on the right side and entire opacification. You always use the terminologies opacity, lucency. When it comes to radiograph, opacity and lucency. When it goes to ultrasound, hyperechoic, hypoechoic. When it goes to CT, you talk about hyperdense, hypodense. When it goes to MRI, you talk hyperintense, hypointense. Whatever is bright is hyperintense. So whenever you're looking at the radiograph, what I'm looking at is opacities and lucencies. Opacity, opacity, opacity. So the entire left hemithorax, where I'm supposed to see the lung, I'm seeing it's all opaque. So this is called opacification of the left hemithorax. So there's a big list for that, but for now, also look at the way the mediastinum, where is the trachea? The trachea is shifted. Look at the trachea, it is shifted. So this is a case of hemothorax, and you are right. So patient was already intubated. By the time we have done CT, they realized the needs to put the tube in there. There are some other findings which will come to that later, but this is a classic case of hemothorax. The one thing which I have to tell you, the young residents is, young medical students is, we always, whenever we see a fluid, yeah, very good, very good. The left clavicle fracture is picked up by Abdul Latif. I appreciate it. So I'll come to that. Left clavicle and upper rib fractures is at the musculoskeletal section, but that's I should give credit to you. And then there is opacification of the left hemithorax. Whenever we see a fluid anywhere, the first symptom the behavior the radiologists have to inculcate is to measure the Hounsfield units. I was talking about the using the terminology, opacity, lucency, hyperdensity, hypodensity, but more importantly, a radiologist will also talk in terms of Hounsfield units. The Hounsfield units is a CT measurement to classify the internal density of a substance. Whenever there is, the blood will have a Hounsfield units around 40 to 70. So this suggests blood. This is a case of hemothorax. So what are all the causes of hemothorax in a case of trauma? It could be secondary to the injury of the lung, which can cause to pleural effusion in hemothorax, chest wall injury, heart injury, and the great vessels injury. All these things can cause hemothorax. So this can be the hemothorax diagnosed on X-ray just functions as a guideline to further management. And also remember that abdominal injuries, including a diaphragmatic rupture, can also cause hemothorax. A massive hemothorax for the treatment purpose, whenever there is more than 1 liter and shock, and it is coexistent with a hypoperfusion, that becomes a clinically significant case there. Okay, this is a chest radiograph in a young patient who came with trauma. So anybody wants to talk about the findings here? The damage is done on the left side. Very good job, Salim and Abdulatif, and very good. There's a stomach bubble, a large guy, Victor. Everybody did a wonderful job here. So what I would say is, looking at a gas bubble on the left side is not a big deal, but you're not able to see the diaphragm, and you're seeing the collapsed lung segment there. So this is a classic case of these are my cases of diaphragmatic rupture, which I always show to my residents. One is, you see, the diaphragm is supposed to be like on the right side and left side. You compare the diaphragms. The left hemidiaphragm is ill-defined, and also you can see a contour bulge. And also you have to notice some amount of atelectasis or pressure on the lung parenchyma. This is a classic case of a diaphragmatic rupture. On the CT, you can see the diaphragm, discontinuity of the diaphragm, both on, So this is due to high energy blunt trauma and leads to sudden rise in intra-abdominal pressure. The positive intra-abdominal pressure results in the diaphragmatic laceration, and the abdominal contents herniate into the thorax. So this is also sucked up by the negative intrapleural pressure. And most of the times, I would say, not all the times, but most of the times, you will be able to identify it on the chest radiographs, but sometimes the sensitivity may be a little bit less, but CT always helps in the management and how to plan the surgical treatment. So the radiographic findings, this is another case of the diaphragmatic rupture. You can see the opacification of the left hemithorax, and you can also, as I always say, there is a pressure on the lung parenchyma. That's what I want you to imagine, the situation, which is the pathophysiology which is going on there. The pathophysiology is at fluid level. So the pathophysiology here is not only the abdominal contents are going into the thorax, they're trying to give pressure on the intrathoracic contents, that's the lung parenchyma. So that causes significant amount of damage to the oxygen saturations or patient's clinical hemodynamic stability. So the abnormal diaphragmatic contour, I don't see. You see the normal diaphragmatic contour here. I don't see it. I see an opacity there, right? And then the intrathoracic air fluid, in some cases I showed you the intrafluid air fluid level in the first radiograph, which I showed you. And sometimes if the patient already had a intrathoracic enteric feeding tube or an NG tube, that will be in the thorax. That's one other important diagnostic clue. And for example, in this case, you look at the trachea, there is a pressure. Even pleural effusion can cause, but a diaphragmatic herniation causes an immediate push to the contralateral side. So the other signs which you need to know are CT is more sensitive. This is called a dependent viscera sign, where you can see the viscera in the dependent area. And this is called this is a collar sign, where the focal constriction of, this is on the right side, you can see the herniation of the liver laceration is also there. And the ruptured diaphragm tries to constrict the area of the herniation liver or bowel or whatever it may be. This is called as a collar sign. And it also always associated with a visceral organ injury. So it is like, it decides the entire management of the patient if you identify all the findings. And the complications of a diaphragmatic hernia, one is vascular compromise, and the other is respiratory insufficiency, which I was talking about, the abdominal contents causing significant pressure. And moving on to the last component of the chest radiographs is the musculoskeletal injury. I gave you the clue. So do you find any abnormality there? Anybody? This is going to be a little tough. So don't beat yourself if you get it wrong. We all here to learn, but we will be learning from some mistakes too. So don't hesitate to. Yeah, I know this is difficult for you guys. Anybody now? I gave you a CT. Compare the one thing which if any of you want to become a good radiologist, one thing is comparing both sides. Comparing both sides. I'm trying to show you some bones. I already gave you, it is about bones. So I narrowed down the differential for you. Any bone, even if you mistaken the site of the injury, like, right to left goof, very good. It is very good. Sternocostal clavicle is higher. You see, you guys are observing. Salim, Abdul Latif, Victor, I really appreciate your participation in this. You guys are following what I'm talking here. So yes, this clavicle is higher, but which one is abnormal is a question. So that's the next level. But at least I got you guys. You said about sternum. This is the sternum. This is the clavicle. This is the sternoclavicular joint on the right side, which is good. But what happened on the left side? Again, I go back to the previous image. Sternoclavicular joint on the right side, sternoclavicular joint on the left side. So that is why this clavicle has gone down. You see that now? So this is a sternoclavicular dislocation, a posterior dislocation, because the vascular structures are there. This is very significant injury. You have to monitor them carefully. You can see the normal sternoclavicular junction on the right side, and supposed to be here. The clavicle is supposed to be here. It moved posteriorly. But look at this radiograph. If you are clinically suspecting this, sometimes sternoclavicular dislocations and acromioclavicular dislocations are better identified by residents than the radiologists. I'm not kidding. I'm not trying to impress you here. I'm telling the fact, because this is a very rare location, and unless you examine the patient clinically, and you will know where exactly is the site of injury. So this is just trying to tell you that because of the vascular structures, you have to be very careful about posterior sternoclavicular dislocations. Usually follows a severe shoulder trauma, posterior dislocation, the mediastinal organs, and great vessels are there. So always they have their own clinical implications. It requires a closed or a surgical reduction. So already some students have picked up the clavicle fractures here. We talked about the left hemithorax, but here my point of teaching is whenever you see clavicle fracture, whenever you see upper rib fractures, it means that it has a severe downward trauma, especially in an MVC. And most importantly, there can be a damage to the great vessels and brachial plexus, which can cause a neurological damage to the patient. So this is where you have to keep your focus. The first rib and the clavicle, both are fractured there. And on CT, these are the ones which have to go to CT, one for hemothorax and one for the upper rib fractures. Whenever you go for an upper rib fracture, this is how the fat looks like. If the fat is obliterated, this is all the blood. On CT, I use the term hyperdensity. The hyperdensity, again, CT Hounsfield units around like 40 to 70 Hounsfield units. So that's the blood there. But what exactly is going on? Some vessel is missing there. One of the vessels, like the left subclavian artery, is not seen there. And the coronal plane, you can see this is the ligamentum arteriosum, and then this is your subclavian artery. It is transected. You can see, you don't see it beyond this level because it is transected. So this is an example to show that whenever you have an upper rib fracture, there's a likelihood of a great vessel injury, mediastinal hematoma. The patient may be in hemodynamic shock. So that is a transection. So this is moving on. This is, you notice a small pleural effusion, some atelectasis. You don't see anything else. But if I show you a bone window thin slice, anybody able to pick up anything on the bone window? We are looking at the bones. Let the medical students know that how the radiology works, how we do magics with our technology, windows. Very good. So yeah, okay, I'll give you the answer there. So that is a rib fracture. So why is it significant? The lower rib, as I said, upper rib fractures are associated with trauma of the great vessels, right? And the lower rib fractures are, yeah, very good. Salim, doing a good job. So this is where there is a displaced fracture. So in this case, you can see the patchy attenuation of the liver parenchyma, which is a laceration there. And also, more interestingly, the right adrenal gland is having a heterogeneous enhancement, elongated with a lot of hemorrhage surrounding the right adrenal gland. This is a case of adrenal contusion and a right-sided liver injury. This is the last case on my musculoskeletal part. Anybody wants to take the case? This is taught in every final year surgery textbooks. The clue I can give you is the patient is having paradoxical breathing. Emphysema, very good. It has emphysema, right? We're talking about very good, excellent, Salim. That's an excellent job by Salim. So he nailed it. So what is the mechanism of a flail chest? This is, I mean, more than 5, or at least sometimes even if there are 3 or 4 also, if it is a segmental fracture, I try to diagnose flail chests on the radiographs. So paradoxical respiration. So what happens is when the patient inspires, the lung volume increases and the chest wall is supposed to expand outside, whereas paradoxically, the fragmented segments, because of the intrathoracic pressure, they'll be pulled inside. Whereas on expiration, when the chest wall is moving in, the flail segment goes up outward. This is called a paradoxical inspiration. So at least 5 contiguous single fractures or 3 adjacent segmental refractures are needed to cause this flail chest. A paradoxical motion during the respiratory cycle, and anterior or usually lateral refractures are more common to cause the flail chest than the posterior, and they severely impair the respiratory function and predispose to collapse of the lung parenchyma as well as secondary infection. But I think both clinically and radiologically, it's unlikely to miss a flail chest in a trauma case, usually treated with positive pressure ventilation, or it needs a surgical fixation for stabilization. But most importantly, if somebody has a flail chest, it is a severe injury and it takes longer time to recover. To summarize my talk for today, chest X-ray plays a very key role. It's a debate whether to do on a hemodynamically stable patients. So I would say rather follow the institute guidelines where exactly you are posted, where exactly you're working. It depends, it changes from institute to institute. You have to remember that all the time. It's able to you should be able to identify critical findings, whether you are in the radiology team or in a clinical service stream or in a trauma team. If these 6 things are taken care, you will be able to identify more and more abnormalities, and you will also decide how exactly the patient is going to course, and then you will also be able to identify what is the next step to be done. So for example, you saw a huge pneumothorax, you don't wait for a CT scanner or you don't wait for a radiologist's call. You will try to confirm it, but your job will be to put a tube there. It guides further management, and I have shown you how exactly a CT finding looks on a X-ray finding looks on a CT chest. CT is always more valuable because of the vascular injuries. These are one of my, I go to a creek nearby my house. I think I saw Judy also once there. So this is the springtime versus the winter time. This is in the winter and this is in the spring. So I love this picture in my collection. And that's all I have for you. Your image is your image is your perception, and your perception becomes your image at some point. We just need to wait. So that's all for today, guys. Hope distal right clavicle fracture. Yes.
Any questions? This is a really, really high yield and very good lecture to make you a good physician. One of the things that I found helpful, I did my internship at Kiambu, was to always ask another, just a little more history about who else was involved in the accident. You know, so
Yes.
Because you may never have everything, but so for example, if I had one patient and all the rest died, that gave me a sense of how severe that injury was, and you should be more aggressive to make sure you don't miss something. Because if you, or also other things that I found helpful were, and I know imaging is getting better, but was that if you found a place where you saw the patients who had like a young male, you know, just a normal young male who comes in and they are very hypotensive or anemic, then you should be very, very concerned because that's unusual. Now, girls in Africa are not, and Kenya are not unusually, it's not unusual to find them anemic. I've been anemic, you know, especially if you don't know their menstrual history or if they just had a baby. But for males, that's usually, you know, an outlier. So just try and impact sort of your clinical acumen. But again, we recorded this lecture. It's very, very high yield. I'll actually be asking Dr. Maddu to share his slides with me, very well organized. And these are things that not just for the exam, you should just be able to know, and they'll help you save a life. Any questions? I see comments about thank you, and I agree this was a great lecture.
Oh, thank you so much for the opportunity.
Awesome. Okay, so next week I'll probably give the PE lecture, and you know, thanks for joining us, and hope you learned something. Have a good rest of the weekend. So there are lots of thank yous, Dr. Maddu. So I hope you can.
Oh, no problem, no problem. Yeah, yeah, I'm reading them right now.
Okay.
Yeah. So yeah. And I appreciate the participation which people are showing. I already called their names, and it's really motivating for me too. Thanks, guys. Have a wonderful time there. Okay.
Awesome. Thank you. Bye.
Bye bye.